The central nervous system lesion is typically non-localizing. In the case of a peripheral type lesion, which does fixate with suppression, we are looking at a peripheral origin for the vestibulopathy, which typically includes the inner ear or the vestibular nerve. The example that is demonstrated on the screen is one primarily of neuromuscular artifact, as we're not seeing any actual pattern of nystagmus in either the horizontal or vertical channels. In this particular case, there would not be any activity with turning on the fixation light. This is just simply to demonstrate some of the artifact that can be seen during this type of testing. It is of paramount importance to coach the patient, to let them know that they must look straight ahead and pay attention to what they're doing at all times in order to avoid some of this kind of phenomenon. It should, however, be noted that in the case of pure vertical nystagmus, that this is always indicative of a central nervous system vestibulopathy. The following additional examples of spontaneous and gaze with fixation testing demonstrate in the first two examples a normal pattern where there is no evidence of spontaneous nystagmus in the spontaneous phase of the testing, and subsequently no evidence of suppression in the fixation portion. The third example, however, does demonstrate some limited nystagmus in the spontaneous portion, which is completely eradicated during the gaze with fixation portion, indicative of a peripheral vestibulopathy. The next section of analysis of the infrared VNG is that of the rotational testing battery. Active head rotation, or AHR, is performed at head speeds of 1 to 3 hertz for both the vertical and horizontal vestibular ocular reflex, or VOR. There is also testing that involves the cervical ocular reflex, or COR, as well as the vestibulospinal reflex, or VSR. Increased VOR gain is consistent with a central nervous system vestibulopathy, while decreased gain is generally consistent with peripheral vestibular pathology. Many elderly patients and closed head injury patients exhibit increased VOR gain, often as the only abnormal finding in the VNG test battery. VOR exercises are recommended when gain is abnormal, and after correlating the physical examination, patient history, and other medical tests and laboratory studies. In this particular example, we see the patient being tested in both the horizontal and vertical positions, and in comparing the head motion as predicted by the computer with the patient's head motion, we see that this is perfectly out of phase, which is an ideal finding. The patient's gain is 75%, which is within the normal limits. Normal gain is typically 75 to 125%. Less than 75 or greater than 125% are abnormals. In the vertical testing, we see only a small amount of head motion along the yellow line. However, with the patient testing, we see good motion, which is out of phase with the head motion, and a normal gain of 91%. Therefore, both of these examples demonstrate normal rotational testing. The following are additional examples of rotational testing in both the horizontal and vertical planes. In the first example, we see normal horizontal and vertical head rotation with a well-defined pattern of rotational data, which in the horizontal plane has a gain of 80% and in the vertical plane has a gain of 109%, both of which show normal tracings. In the next two examples, there are exaggerated abnormalities in both the vertical and horizontal planes, with the first example demonstrating a gain of 56% horizontal and 65% vertical, both of which are abnormal. This patient would have significant ataxia. The next example shows a markedly decreased gain in the horizontal channel with a markedly increased gain in the vertical channel. The next example demonstrates an asymmetry between the horizontal and vertical channels, again with a normal evaluation in the horizontal channel and with significantly increased gain in the vertical channel. Another example of an ataxic patient. The last two examples demonstrate first an abnormality in the vertical channel as opposed to the horizontal channel, where the vertical channel demonstrates an increased gain, most significant for central pathology. And in the last example, there is an increase in both the horizontal and vertical channels, again significant for central pathology. Lastly, there is a normal reading in the horizontal channel and an increased gain in the vertical channel, again consistent with central pathology. The torsion swing test utilizes not only a rotary type of chair maneuver, but also utilizes a fixation testing to determine peripheral versus a central type lesion. In the case of the torsion swing testing, the patient's head is held in an immobilized position while the patient's body is rotated from side to side. In this particular test, nystagmus can be induced and is normal. The absence of nystagmus is abnormal. Additionally, once the fixation light has been turned on, it is expected to see a 50% or greater reduction in the degree of nystagmus. This particular example demonstrates a normal torsional swing testing. In this, we see sinusoidal type nystagmus, which is repeatable and which is well formed. At the extremes of the testing, there is some muscular artifact. Once the normal nystagmus is elicited with the testing modality, the fixation light is then turned on, where we observe a greater than 50% reduction in the degree of the sinusoidal nystagmus. This represents a normal finding and is what is expected to be seen with this testing modality. During this portion of the oculomotor testing battery, it is of absolute importance for the technician or physician to keep their eyes on the screen to actually observe the nystagmus that the patient is exhibiting through the infrared oculography, so that one can tell if there is well-formed nystagmus and the response of the fixation maneuver. Additional examples of torsion swing testing and torsion swing with fixation are demonstrated with these tracings. In the first two examples, we demonstrate a greater than 50% reduction in the degree of nystagmus, which is elicited by turning on of the fixation light. These represent normal tracings. In the next two tracings, we demonstrate some abnormal findings with a less than 50-degree reduction in the degree of nystagmus after the fixation maneuver is performed. This is indicative of central vestibulopathy. In the final three examples, there is no decrease whatsoever in nystagmus, or in fact, an increase in the degree of nystagmus, again consistent with central vestibulopathy. These examples demonstrate the absolute need for the operator of the testing equipment to be very attentive to the degree of nystagmus, which is seen through the infrared goggles on the television screen. The next portion of the testing battery is that of positional testing, which is divided up into several individual positions as well as a more specialized area of testing called the Dix-Hallpike examination. It is a dynamic test of changing positions. It can be done in a full lighted setting, but the eyes should always be watched and the nystagmus should be closely observed by the operator or by the physician. This is done by watching the television screen and making note of the nystagmus that's observed. The key to the diagnosis of benign positional paroxysmal vertigo, or BPPV, is the presence or absence of torsional, that is to say geotropic type nystagmus, with the rotational component beating downwards towards the earth. The technique of the testing has been discussed in another video, but briefly to review, the head is turned 45 degrees to the left or to the right prior to laying the patient down in a 30-degree head hanging position. Hyperextension of the neck is unnecessary. Both eye movements and symptoms are important, and nystagmus is again rotational in the presence of benign positional vertigo. Additionally, there is a latency, which is typically of short duration, a few seconds up to 30 seconds, and is usually accompanied by vertigo and fatigues, typically with repetition of the maneuver. Again, a diagnosis of benign positional vertigo, or BPPV, is classic when geotrophic nystagmus is noted. In the following example, infrared oculography is performed in both the horizontal and the vertical channels. As noted in the horizontal channel, there is one beat of right beating nystagmus, which is in the proper direction because this represents a right ear. And in the vertical channel, some 5 beats of upward beating nystagmus are noted. In this particular patient, a careful observation of the type of nystagmus observed was noted as rotational or torsional. This confirms the diagnosis of benign positional vertigo. In this particular patient, it was of paramount importance to observe the nystagmus as recorded by the infrared goggles, because under ordinary circumstances, especially in the vertical channel, some of this may have been felt to be muscular artifact. The following examples are taken from additional Dix-Hallpike studies and will be discussed at this point. The first 2 examples demonstrate a recognizable pattern of rotary or torsional nystagmus, which in the first case demonstrates a horizontal score of 2 beats to the left and a vertical score of 5 downward beating examples of nystagmus. This is diagnostic of benign positional vertigo in the left ear. A right-sided example is also provided, demonstrating 2 beats to the left and then 5 downward beats, again diagnostic of benign positional vertigo in the right ear. The next example demonstrates a lack of response in both the horizontal and vertical channels.